Okay. Well, welcome. We're going to talk today about prostate cancer, what it is, how it forms, how it's commonly diagnosed and treated in standard care today in Canada and elsewhere, and the most current innovations and how to access them. So that's what we're going to cover today. My name is Michelle Morand, and I am presenting this along with my compadre, Alexander Rowland. We affectionately refer to him as the cancer guy because for decades, that's pretty much been, well, with the exception of a few other things, all he does. And his happy place is to be up at 3 a.m. looking at the most recent journal articles, seriously. So this is in your best interest because he is very much up to speed and his team are really crackerjack. So we're going to hear from Alex about the most current things, kind of big problems with standard care in prostate cancer, things to look out for, things to ask for, and most importantly, those innovations in treatment. We've been doing this work, cancer treatment options and management, for 11 years now. It's a personalized research and education and advocacy group. And we started out in Vancouver, BC, and now we provide services all around the world, really just helping cancer patients and their oncologists have access to leading edge treatments sooner than they otherwise would. So I just wanted you to know a little bit about us and what we do. Alex, is there anything you'd like to add to tell us a little bit about yourself?
I think you pretty well covered everything, Michelle.
Right, that you're up till 3.
I'm up till 3 in the morning reading journals.
Yeah, pretty much, or in the lab where you are right now.
Yes.
Yeah, that's your happy place.
I'm in the Cetome DNA sequencing lab right now, actually.
Yes, you are, with that's a big freezer behind you, right?
Yeah, we have many freezers. They're required in this.
Samples nice and cool. And we might get to talking about that if people are interested a little bit later about some of the new technology you have in your lab and some of the testing you can do there. Nice to see you, Michael. Thanks for joining us. Good to see your face. All right, so what I'm going to do is I'm going to disappear, and instead of me, we're going to see this PowerPoint presentation so that Alex can talk us through it. I'll also do my best to try to keep an eye on when you've raised a hand or have questions to ask, but again, we may just save those for the end of each section. Okay, so I'm going to share my screen. I'm going to see that, and I'm going to go to slideshow. Okay, can you see that, everybody? On the one half of the screen? Okay. What's most interesting is what Alex is about to say, but it is kind of nice to have something to follow along with. And again, everything that we're about to cover here and then some is in that document that I loaded into our chat and is also going to come to you in email when we're done. So don't worry if you're having a hard time seeing all the stuff. It's coming through. Just sit back, enjoy, listen, make a note of any questions you have. Okay, so as mentioned, we're going to talk about what prostate cancer is, how it forms, how it's traditionally treated in standard care, what are the most current innovations in diagnostics and in treatment, why they are so much better, so you can really understand the mechanisms behind them. And that'll help you with your advocacy. Alex, here's just a couple notes here, but you go ahead and riff along about what is prostate cancer.
Yes, well, for starters, Michelle, I'd just like to say what an amazing presentation you put on here. I have to give full credit to Michelle for this. She just basically interviewed me and asked me my thoughts on it, and she put all of this together herself with her and her team. So I think she definitely is owed a lot of gratitude for that because she did a wonderful job here.
Thank you. It's got 11 years of practice translating so that people can understand you.
Yes. Yeah. Okay. So I guess the big question is, everyone wants to know what prostate cancer is. I mean, apart from having a tumor in your prostate, which is what most of us know as prostate cancer, there's a lot more to it that's really important, that is important to understand in terms of how prostate cancer is treated and where the technology is going. And so, as Michelle's put on the slides here, everything in prostate cancer is based on the androgen receptor. And so, might ask, okay, what is the androgen receptor? The androgen receptor is basically a docking station. And I like to consider this as an analogy to a shipping bay of a business. Whenever something is to go into the business, you don't see the workers typically, or the FedEx guy, you don't see him delivering stuff through the front door, past all the offices and so on. They typically go to the shipping dock. And that's the same with cells. I think there's a lot of analogies in life that can repeat themselves at different levels of complexity. And I think this is a perfect example. Androgen receptors like a shipping bay. So a receptor basically binds something called a ligand. And the ligand can be many different things. In this particular case, the androgen receptor we're concerned with binds testosterone. And when it binds testosterone, it creates a signaling cascade that causes the cell to grow and proliferate. This is a normal standard process that goes on throughout our life. This is just a normal, healthy process. So what is a cell surface receptor? Well, I generalized over this a bit, and you'll have to excuse me because the way I explained it is I wanted people to understand that receptors basically are like a docking station. However, there's a variety of different types of receptors. Some receptors poke out to the surface, and they're called cell surface receptors. And then others remain inside of the cell. So if it's a small molecule like testosterone that can normally enter a cell naturally, then typically the receptor is going to be in the inside. More importantly, the androgen receptor, there's a variety of different androgen receptors. In fact, there's a whole class of androgen receptors. They each have their own names. There's about 4 of them, and each one, they're called androgen receptors, but they each have their own specific name and specific function. And they are cell surface receptors, and they're all over the body, in different cells all over the body. So they're not really involved with prostate cancer. The prostate cancer androgen receptor we're concerned with is actually referred to as a nuclear receptor. So it's just inside of the cell membrane. And what happens is the testosterone comes inside of the cell naturally, or through channels, and then it binds onto the receptor. And then the whole androgen receptor complex plus the testosterone gets transferred down to the nucleus of the cell, where it binds onto a bunch of different genes, and they're called DNA binding elements, and it activates a multitude of different genes. So it's not a simple signaling pathway. There's a cascade of events that turns on what they call androgen receptor associated genes. So once again, the ligand binds onto the receptor. Whether it's on the cell surface or whether it's just inside the cell, it's irrelevant. It's a receptor. And then it causes a change in the shape, or in this particular case, it translocates to the nucleus and binds DNA in this particular case. So what is prostate cancer? Well, prostate cancer is usually defined by overactivation of certain genetic elements. And those elements are involved, typically what we refer to as a wound healing process, or it's a growth process. So in our bodies, we have basically 2 types of genes. We have 25,000 or so different genes. And some of those genes are maintenance genes. They're turned on all the time. And then others are kind of growth genes. And they're only turned on briefly to repair damage or for us to grow. And as you know, our bodies are constantly growing throughout our lives. Our bones get changed completely about 8 to 12 times throughout our life. So, all of our cells get constantly changed, with the exception of some nerve cells. So what happens in cancer is you get certain mutations in the genes that are only supposed to be turned on briefly, the ones that we call wound healing, that repair damage to different tissues. They only get turned on briefly, then they get turned off. They get activated, so they get turned on permanently. And then we have a class of genes called tumor suppressors. And tumor suppressor genes, basically what they do is they will inhibit any cell that's rapidly reproducing. So in cancer, you get damage to both classes of those genes. And so I like to think of those as the brakes and the gas pedal. So tumor suppressors are like the brakes of a car, and oncogenes oncogenes are basically the gas pedal of the car. So just to cover, in prostate cancer, the specific mechanism is all related around this androgen receptor. So what happens with the androgen receptor is you'll have an abundance of these androgen receptors. You'll have too many of them, or there's a unique alteration. Everyone's androgen receptor is unique, and it's unique in the DNA. So the DNA has what we call CAG repeats. And CAG is just 3 different base pairs of DNA. So these repeats occur, they're called CAG repeats, and they occur in the gene of the androgen receptor. And so if you have a small amount of these CAG repeats, then your androgen receptors are really sensitive to any circulating androgens, and specifically testosterone. If you have more repeats, then you have decreased sensitivity to androgens. And one example of this can be seen in African American males. They have a decreased amount of these CAG repeats, and therefore have a heightened sensitivity to circulating testosterone and androgens, and that gives them a higher risk factor for prostate cancer. So with prostate cancer, you have an abundance and an overactivation of this androgen receptor. And it's caused by testosterone, which is its ligand, its binding activation ligand.
Thank you. Oh, hang on a second.
I'll make a ding sound when I want you to change the slide.
Okay. I'm assuming that was the ding. Okay.
Just like my daughter's talking books. Okay, so the standard care for prostate cancer, as you might imagine, is targeting testosterone. Now, there's a few things else about prostate cancer. One of the way it's diagnosed is by something called PSA, prostate specific antigen. And that's basically something that is mostly found in semen. It's produced by the prostate. There's small amounts of PSA, ordinary circulating throughout your body. But in prostate cancers, they tend to have an elevated amount of this PSA molecule. So it's being used to determine whether someone has prostate cancer if it's over a certain threshold. Now, that's not the case for every case of prostate cancer. We've seen cases where the PSA was low and the person had a very aggressive disease. And we've seen cases where the PSA was really high and the person didn't have prostate cancer. So PSA can occur from high PSA can occur from a variety of different conditions, hyperplasia, but it is an indication typically a general standard care indication of prostate cancer. And so in order to determine certain things in prostate cancer, they look at how fast your PSA increases. And we'll get into doubling time a little later on. It's used in a different criteria. But typically the diagnostics for prostate cancer are typically a scan, such as a CT or MRI. And then if you do have a lump, they will take a bunch of biopsies from different parts of the tumor or the prostate, and they will take these little biopsies and they will convert them into a risk factor called the Gleason scale. I'm sure all of you know what the Gleason scale is. It's basically a prognostic index that tells you the aggressiveness of the cancer. Another thing that can happen is people can have bone lesions prior to knowing they have prostate cancer. So often a bone scan is done because prostate cancer is preferentially metastasized to the bone. Okay, ding.
Oh, ding.
So precision oncology is very different. Precision oncology is a science of where general prostate cancer treatment is going, but it may not be here yet. And there's a big difference between what is being done in some places and what is being done in all places. And I think a perfect example of that, when people say, well, if this, amazing technology is available, why don't we have it at my local hospital? And I like to use the analogy of, why don't we have clean drinking water for all Canadians? Maybe if we get that solved, then we can go on to more complicated things, such as getting some of these advanced treatments around. However, if you have prostate cancer or any type of cancer, what is really important is knowledge. Knowledge is power in anything you do. And so if you know the technologies that are available, then you could go out and seek them. You don't have to sit back and wait for them to come to your local hospital, which could take 10 years. You can actually say, well, I've heard of this new technology and I would like a part of that. I've looked at the data. It's amazing. It's much better than what my doctor's offering me. So I'm going to go to that hospital and get that. And often you can actually have that technology here, just in a local hospital, but you'll have to pay for it privately. And that's not always discussed because a lot of times the doctors don't know what's being available private, what's going on. So a little bit about diagnostics for prostate cancer. Something called the PSMA PET. It's been around for quite a while. And in fact, the technology has been around in Canada, has been really forefronted in Canada for a long time. However, for some reason, it's just, it's not being used on a regular basis. There's been clinical trials where they've used it, but I suspect the cost of the scan is a big problem why the Canadian government is not completely doing this. But you can get PSMA scans and there's private facilities across Canada where you can get them. So basically, what is a PSMA scan? Well, the PSMA molecule is called the prostate-specific membrane antigen. So the membrane refers to the outside of the cell, and antigen refers to typically a polysaccharide or some sort of molecule that is unique to a cell type. And it helps the immune system determine, this is a cell from this area, or this is a cell from this area, and it should be in this area. So with PSMA PET, what they do is they have this molecule that will bind onto PSMA. So basically 99% of prostate cells have this PSMA molecule on their surface. And if you have a prostate cell that's somewhere else in your body, then that's not a good thing. That has to be a metastatic prostate cancer. So prostate cells can only live in the prostate unless they're cancerous. So the idea of the PSMA PET is it's a molecule. It's much like an antibody. In fact, the early PSMA PETs did use an antibody, but now they use a much more efficient small molecule. And this molecule, when you inject it into the blood, it will seek out every cell in the body that has this PSMA molecule, and it will bind onto it. So what some brilliant scientists did was they thought, well, let's attach a radioactive tracer to this molecule. And then what we'll do is we'll inject this radioactive tracer and this small molecule into the person's blood. We'll wait a couple hours and then we'll give them a CT scan and see, and that should allow us to detect every single prostate cell in the body and detect metastasis. And so they did that, and sure enough, it worked incredibly well. And so PSMA PET, as you can see, is about 92% accurate at detecting metastasis, whereas a CT and bone scan combined, the two together, two independent scans, are 65% at best. So it's really important to understand if you have metastasis in your body, because the treatment is very, very different if you have metastatic disease and if you don't. Mm-hmm. Ding.
I'm gonna get you a proper bell here.
Yes, I should hear a little ring a bell, yes. So the standard treatment for prostate cancer typically follows treatment that we have for many different cancers, and that would be surgery. And surgery is always the best way to get rid of a cancer, providing it hasn't metastasized.
Oh, Alex,
yes.
Sorry to interrupt you, but truly with good intent. What I didn't write in here, because I wanted to ask you more, and now's the perfect time. In my reading and preparing this document and getting ready for this presentation, there was a lot of talk about how in standard cancer care, based on folks' PSA number, even if something is there, and even if they know it's malignant, watching and waiting is a very common approach. I didn't put it on here, but can you speak to that as well?
If you have a low-grade prostate cancer, by the Gleason scale, typically that means it can be very slow growing and it may not be a problem and it may not metastasize. And there are definitely cases of that. We kind of live in a different world at CTOME. We get all the difficult cases. If there's cases that are unique and difficult that don't respond to standard care, they usually get sent to us. But importantly, the waiting method is never a good idea. I understand in a political sense and a business sense, when you're dealing with a lot of people, you want to stratify cost versus risk. And that's part of standard business model and statistics. But if you are an individual, and I speak to the individuals because our goal is to work from the bottom up rather than the top down. We want to work with the individual patient and we want to look out for the best interests of the patient. We're not looking out for the best interest of the medical system. We're looking out for the best interest of the individual person. And so if you're being told to watch and wait, I would say don't. Get it out. There's a chance that they're wrong. And if you haven't looked at the genetics of your cancer, the Gleason scale is not necessarily the only thing that can be done. There's a lot of variation in prostate tumors. In every tumor, you can get a biopsy of a non-aggressive part, and then there could be a very aggressive component of that tumor that the biopsy just missed. And in fact, often the case is that once a tumor is removed, it usually has a much higher grade than the biopsy originally confirmed. So when you get a biopsy, it may be grade 2 or 3, and then after surgery, oh no, sorry, we've actually now seen that it's actually more like a grade 7 or 8. So yeah, surgery is always the best with cancer when possible. And in Canada, they like to do a lot of waiting and seeing because it's cost effective. Mm-hmm. Mm-hmm. So surgery, and then there's also brachytherapy. There's external beam radiation that was used for many years and still is. Brachytherapy is where they put little rods or tubes, little radioactive rods, and they insert them around the tumor. They can also use little tubes where they actually run a radioactive solution through the tubes, kind of like on a car, the radiator of a car. And so that radioactive fluid is put around the prostate, and they do that, a few times. The rods are installed directly around the tumor. So, brachytherapy is an effective treatment, but once again, you're leaving the tumor in, you're leaving the tumor microenvironment in, and often the things that cause the tumor, the stem cells that have caused the tumor in the first place are, 5-6 centimeters, sometimes, depending on the organ, of course, are a short distance away from the actual tumor. So once again, surgery is always best. Okay, you can switch.
It's also going back to those diagnostics we were talking about. Like you just mentioned, problems with biopsy, that things can be misgraded, which of course is a critical element. But as you were talking about those scans, right, the accuracy of a CT scan versus a PSMA in terms of determining metastasis and all that kind of stuff, because those diagnostics will determine the success of your surgery, the successful placement of the brachytherapy rods, whether this first line treatment is even the right thing for you. So that those early diagnostics are just making sure wherever you're at in your process, what I see as a supporter and advocate for cancer patients is making sure that diagnosis is as thorough and accurate as possible is so critical.
Exactly.
Because once you have that information, then the public healthcare system kind of loops back in and can provide you what you need. You can't argue with the data.
Exactly. And I have a personal circumstance that I would like to share briefly on that situation. I had a routine scan last year, and just a routine health scan. We noticed that there was a little cyst on my kidney. And so the doctor said, oh, it's probably nothing. These things crop up all the time. We can just follow it and watch it. And I thought, yeah, I don't think I like that idea. I think I'd like a little more thorough. So I went out and paid for a second scan. And that kind of gave the indication that, yes, there is something here. But luckily, there's no other lumps anywhere else in your body. So, it's more likely to be a cyst and not a metastatic tumor. So I took it one step further and had a dedicated kidney scan, and that came back and they said, this is, probably a low grade tumor because it had a lot of blood vessels around it. So I spoke to the urologist and he says, we'll just watch it. It's not going to do anything. It's fine. Let's just leave it. And I said, I want it out. And so after much arguments and much wait, I finally, luckily, was able to get it out. And after they took it out, it was considered a very low risk, low grade. But when they actually took it out, it was still very small. So it was 1.8 centimeters, which is considered, somewhat very early stage. I was very lucky that that I caught it when I did. But surprisingly, it was upgraded significantly to a moderate to high grade tumor. So that would have been incredibly high risk had I left it in. And if I hadn't pushed and you had it taken out, if I had gone with the suggestions of the doctors, it would have been a very bad thing within a year or two for me. Mm. So be very aggressive. Understand that the doctors in the private system are working for, or sort of the public system are working for maintaining the public system, and they're basing things on a cost versus risk basis. You don't want to do that. Your life is not a cost risk basis. Mm-hmm. You need to do that and really be aggressive in your diagnostics and make sure everything's okay. Mm-hmm. So, as I'm sure most people are really interested in understanding what can be done in metastatic prostate cancer, because really that is the problem disease, we're going to switch gears a bit and we're going to talk about what sort of treatments can be done. So typically, as you understand, ADT is the standard care. And most people are quite familiar with ADT, LHRH antagonists, that basically what they do is they stop the production of testosterone. And so the goal there is, if you don't have any testosterone binding your androgen receptor, then there's nothing to turn it on and it's just going to stop growing. And that is the case for tumors that haven't metastasized. However, that's not everything. So what do you do for metastatic prostate cancer that's spread beyond the prostate or that's very aggressive? Well, another approach is to target the actual androgen receptor. And so I like to use the analogy of pouring cement down the drain. And that's what androgen receptor antagonists do, is they plug up the androgen receptor. So they bind onto it and they prevent testosterone from binding it. Now, it's a lot more complicated than that. And there's a variety of different mechanisms, and there's a bunch of different androgen receptors that have a different function and that work in a different way. There's what we call the second generation androgen receptors, such as enzalutamide and apalutamide. And then there's abiraterone, which is what we call a steroidal receptor inhibitor. So basically, there's 3 that are approved for metastatic prostate cancer, and 1 that we really like that is just being in the approval process now. So, ding.
Nope. Oh, did I? Yeah, that's right.
So I'm sure many of you have heard of castration resistant prostate cancer, hormone resistant. And basically what happens is when, and this is really a rough way of, can you go back?
Yeah, sorry about that.
This is something that I'm not crazy about in the treatment of prostate cancer in standard care. Is a lot is put on the PSA levels, and more importantly, the time period that the PSA levels double. So if your PSA level doubles within a certain time period, then they consider you somewhat castration resistant. And they say, oh, you're not going to respond to either ADT or AR antagonists. And therefore, we're just going to give you chemotherapy. So the benefit of AR antagonists is that they bind the androgen receptor and prevent testosterone from binding it. However, what can happen over time is the androgen receptor can develop mutations in it. So it changes its conformation. And now all of a sudden, these androgen receptor antagonists can't bind onto it because it has a different binding shape. And therefore, and also what can happen is these androgen receptors can get mutated, so they don't need testosterone to get turned on. And so they have what's called constitutive signaling. And so that's one of the things that causes aggressive disease and causes treatment resistance and castration resistance. There is a new drug that I really like that's just in the approval process. In fact, it's available now, I believe, in Canada. It's called darolutamide. You've really got to push for it. I know many Canadians have been on it so far, but a lot of doctors, when you ask them about it, they just, oh, well, I don't know, they're not quite where it is. You want to push for darolutamide if you have metastatic prostate cancer. The reason is one of the problems, and this is a significant problem why doctors don't like to use AR antagonists right away, is because they do have some serious side effects. And one of those side effects is that they enter the central nervous system, which is the brain and the spinal cord and so on, and they cause problems. And some of the problems can be insomnia, they can be irritability, they can cause strokes in certain cases. So a lot of doctors like to put off AR antagonists for a long period of time before giving them. And that's a problem because they're very beneficial and they can significantly increase survival rates and reduce the spread. And you want to reduce the spread of cancer as early as possible. So darolutamide is a new generation AR antagonist, and it has limited penetration of the blood-brain barrier. So it doesn't have all of these other side effects. It also works against the androgen receptors that have mutations and have changed conformation because it binds a different area of the androgen receptor than the previously designed AR antagonists. So it really is a great new drug, doesn't have the adverse side effects, works for castration-resistant prostate cancers, and works against mutations in the androgen receptor. So that's the golden drug that you want to look for if you're going to be taking an androgen receptor. Okay, so we haven't really discussed much about targeted therapies. Targeted therapies are really what precision oncology is all about. So a targeted therapy is a drug, and there's many examples, that target a specific molecular feature or mutation. And so since the creation of the Human Genome Project, most of the drugs involved in cancer have been targeted therapies. We haven't really done any new chemotherapy drugs. There's been some alterations of chemotherapy drugs, but we haven't really created any new ones. We've just, still using the same old 50-year-old chemotherapy drugs. So targeted therapies basically are only good for someone that has the mutation that the drug is designed to target. And they're very selective and they work quite effective. So typically what we do for any person with cancer is we will isolate the patient's tumor cells, and then we'll extract the DNA and we'll do something called tumor DNA sequencing. We'll also do expression testing, but tumor DNA sequencing basically takes about 500 to 600 genes and then looks at the mutations in these genes. And these are genes associated with cancers. And then it comes up with allows you to come up with a combination of drugs that target the mutations that are specific to your case. And expression testing looks at about 20,000 different genes, and it looks at the expression of these genes in the cancer cells and compares them to normal tissues. So expression is at the actual amount. So these two tools together are very powerful, and they allow us to come up with all kinds of different treatment options that would never be assessed in standard care. Often these are off-label treatments. For example, we're using breast cancer drugs in prostate cancer patients, and brain tumor drugs in breast cancers. So there's all kinds of different approaches, off-label drugs, and these are the tools that tell you what works for you. Unfortunately, while they have gone down significantly in cost, they're still fairly expensive, but it's well worth the money if you can afford it. So you've probably heard of the BRCA1 and 2, BRCA1 and 2 mutations. They were first identified in breast cancer patients. BRCA1 and 2 are what we call tumor suppressors. They maintain the integrity of the genome. And if a cell has certain types of mutations, then these genes get turned on and they're involved in either fixing the mutation, or if they can't fix the mutation, then they will prevent that cell from growing and dividing. And often they will cause that cell to go through programmed cell death called apoptosis. So we find a lot of BRCA1 and 2 mutations in prostate cancers. And right now, there's 2 drugs, olaparib and rucaparib, and both these drugs have been FDA approved for prostate cancer. So you want to be looking for mutations in BRCA1 or 2 to see if these drugs are options for you. And there's also a bunch of other genes associated with BRCA1 or 2. We won't get into that now. We call that BRCA1/2 NES. They're the associated genes such as ATM and PARP, and lots of different genes that are also associated that can tell us whether PARP inhibitors will be effective. Ding.
Okay.
Also, there's a new class of drugs called immunotherapy, and immunotherapy is really the key to cancer longevity and what we call long-term durable remissions, also known as cures to certain people. So basically, what happens in cancer is the immune system is shut down, and there's about there's probably 11 or 12 different signaling pathways or signaling cascades that we know of that tumor cells use to shut the immune system down. And the reason they do this is for 2 reasons. Number one, tumor cells and the immune system use the same foods. They use the same growth hormones. So when an immune system is in the tumor microenvironment, it causes inflammation, and the tumors feed off of that inflammation. So inflammation is basically the immune system gearing up to fight an infection. The actual inflammation is the immune cells in an area of infection, and the immune cells release all of these growth factors to cause amplification of the immune cells in the area of the infection or the area of the tumor, which is the same thing. And then what happens is, in the case of cancer, the cancer shuts down, waits for these tumor cells to produce all these proteins and foods and growth factors, and then it shuts them down and feeds off the foods they've supplied. So right now we have 2 well-established immune treatments, and they work on 2 of those 11 pathways I mentioned. There's actually a third one, but the first one is called PD-1. It's called Programmed Death 1. And then the other is called CTLA4. And so we have a bunch of different PD-1 inhibitors. We were the first company to use them in Canada. And we used them on a woman with metastatic melanoma who literally had months to live. She had tumors all over her body. She did 4 shots of a PD-1 inhibitor and 4 shots of a CTLA4 inhibitor. And it just eradicated all of her tumors, and she's still cancer-free to this day. So if you're looking for a cure, immune checkpoint inhibitors such as PD-1 inhibitors and CTLA4 inhibitors are the closest way of doing that. Since then, we've got all kinds of examples of patients that were on death row, and they're completely cured now. So you get durable long-term responses typically from PD-1 inhibitors. It's not always the case. So the big problem with these drugs is determining whom is going to benefit from them. And so we have a whole checklist of genetic features that we look at that help determine, the percentage of a chance of you responding to either a PD-1 inhibitor or a CTLA4 inhibitor. And so these drugs are available in Canada. They're approved for certain cancers, but they're not well distributed. But you can pay for these drugs out of pocket if you want to. So what I call the lottery card, when you get your tumor DNA sequencing, if you have something called high tumor mutation burden, and that refers to how many mutations you have per million base pairs of DNA. So high tumor mutation burden is referred to as having 10 or more mutations per million base pairs of DNA. So, sometimes we'll see patients with 250 base pairs or 250 mutations per 10 million base pairs. And those patients have exceptional responses to these drugs. So this is another reason to get tumor DNA sequencing, because that's reported. You get your tumor mutation burden. You also get something else called MSI, which is microsatellite instability. And you also have something called mismatch repair. All of these can indicate whether immune therapy or PARP inhibitors will be beneficial for you. So a really good reason to get tumor DNA sequencing. Ding. One of the common features we see a lot of in aggressive prostate cancers. Now, it's surprisingly how many times we get a patient come to us and they say, oh, my Gleason was 6. The doctor said, you're fine, everything's good. And then, a year later, the tumors come back full bore. And they say, I don't know what happened. Everything was supposed to be good. So typically, it's the genetic mutations that determine whether a tumor is aggressive, not necessarily the Gleason score. So one of the common pathways that is overexpressed in prostate cancers is the AKT, PIK, mTOR pathway. And we find that a lot of aggressive prostate cancers have something called PTEN loss or AKT or PIK overexpression. So basically, when PTEN is a tumor suppressor that acts much like BRCA1 and 2 does, and when it's lost, the cells can grow uncontrolled. In fact, BRCA1 uses PTEN to prevent cells that are mutated from growing and copying themselves. So uncontrolled proliferation is basically what we call prostate cancer or cancer. So a recent trial looks at AKT targeted drug called ipatasertib. It was in metastatic castration resistance. The preclinical data was really good. The trial has gone up and down. So it's beneficial in certain patients with certain mutations. We're not sure entirely what the outcome is for this drug, but there's other drugs in this pathway that are somewhat beneficial depending on what mutations you have. So you have to understand that a specific AKT inhibitor, ipatasertib, will only work against certain AKT mutations or mutations in that pathway. It won't work against all of them. And that's why sometimes these trials don't look as good as they do, is because they don't look at the different mutations. And they say, well, this patient has this mutation and this patient has this mutation. And to give you an understanding, the scale of the possible mutations that you can have, we have 25,000 genes roughly. Some of those genes are 10,000 base pairs long. A base pair is the fundamental unit of DNA. There are 4 base pairs, and they're named based after the amino acid they're attached to. So you have C for cytosine, G for guanine, A for adenine, and T for thymine. And so it's the order of these base pairs that creates the structure of the gene. So when you change one of those base pairs, if you change an A to a T or a G to an A, then you're going to get a change in the structure of that gene, and that is called a mutation. And so a damaging mutation is what will cause the gene to become oncogenic, or if it's a tumor suppressor, it will prevent the gene from functioning properly. So just to look at the possible different mutations, the way to calculate the amount of mutations that are possible in a gene is you take a look at the different base pairs that can occur in that position, and that would be 4, the A, the G, the C, or the T, and you put that by the power of the length of the gene. And so if that gene is 10,000 base pairs long, some genes are 200,000 base pairs long. So if you have a gene that's 10,000 base pairs long, for example, then you would take 4 by the power of 10,000, and that would give you all of the possible mutations. So I don't suggest trying to do that on a calculator, but I will tell you, if you only take 150 base pairs, which is a minute little fraction of a gene, 150 base pairs, and you take 4 by the power of 150, the number is significantly higher than all of the atoms in the known universe based on hydrogen. So all of the atoms. So that's a massive number that can occur. So the amount of possible mutations in even just 150 base pairs, let alone 10,000 or 230,000, is just exponentially huge. It's a number we can barely look at. So one of the things with tumor DNA sequencing, it looks at all of the mutations and detects whatever mutation is occurring in that gene. So very important. If you do get tumor DNA sequencing, don't get what they call spot testing. Make sure that they look at the entire length of the gene, or as much of the gene as possible. Okay, you can move on. Okay, so another new trial that was kind of exciting, and this is just up last week, so I wanted to include it. There's new stuff every day, almost literally in cancer. There's probably 300 different cancer symposiums every year internationally. The biggest one, ASCO, American Association of Clinical Oncologists, sometimes has 7,000 or 8,000 different abstracts. So, if your doctor says, oh, I went to ASCO 2020 or 2019, I guarantee you they did not look at the 8,000 different abstracts. They probably went to 5 or 6 different presentations and spent a bunch of time, going to wine and cheese meetings and so on. So it's important to understand that these 8,000 or so different abstracts all are based typically on a unique mutation and a unique combination of drugs for that mutation. So when you do your research for your set of mutations, you need to do it in real time, because new drugs and data on new mutations changes literally daily. So this was just up last week, a drug called cabozantinib combined with a PD-1 inhibitor called atezolizumab in metastatic castration-resistant prostate cancer. So in this particular trial, the disease control rate is a statistic we use. What it refers to is the types of responses you have. So when you're given a drug, it's stratified, the clinical trials stratify it by response rates. So a complete response is when, all of your tumors shrink. A partial response is when some of the tumors shrink, but others just stay the same. And then a stable disease is when the tumors don't shrink and don't grow. And then progressive disease is when the tumors grow, or some of the tumors grow. It's a little more complicated than that. They use, a size ratio of 30% and so on. But that's the general gist of the different responses in what we call the RECIST criteria for solid tumors. So the disease control rate is all of the positive responses, which are a complete response, a partial response, and a stable disease added together. And so 80% a disease control rate is pretty good. And so those are patients with high risk features, PTEN deletions, AKT signaling pathway mutations, something called the androgen receptor V7 or V9. So in this trial, 80% among patients, the very high risk of response rate. So yeah, the response rate refers to how many patients responded, overall response rate. So in this particular study, 67% of patients had a PSA decline of at least 50%. So that's using the PSA scale. Some of those patients, PSA was not a good indicator, so you have to consider that too. So if you could go into the next slide. So I'm going to talk about an amazing new field now, and there's a lot of amazing new fields in cancer treatment. This is something called Theranostics. And so if you recall, we'll go back to when we discussed the PSMA PET. So just a little primer on that again, in case you forgot. PSMA is a prostate-specific membrane antigen. It's that antigen, and an antigen is referred to as an antibody generator. In other words, an antigen is something that creates an antibody in the body. So So in this particular case, this is something on prostate cells, and it's so the immune system could recognize them as prostate cells and make sure they are where they're supposed to be. So when these scientists are developing these PSMA binding molecules, one of the things they found that was really interesting, and I would like to say that a lot of the PSMA technology has been developed in Canada in universities. Unfortunately, Health Canada still is not approving it for treatment. Australia has been using it for many years. Germany's been using it. They've been a hotbed of Theranostics technology. And now you can actually go to India and get PSMA treatments now. So it's being used all over the world now. So PSMA PET, once again, it's a small molecule bound to a radioactive isotope. They inject it into you. This small PSMA seeking molecule will bind onto any prostate cell, and then it will glow when you put it under a CT scan. So some of these brilliant scientists that were doing this noticed that after this PSMA scan, some of the patients actually had smaller tumors. And they thought, okay, what's going on here? Is the radiation from the scan that's targeted to these cells, is it actually killing the cells? And yes, it actually was. So they thought, wow, we can actually do targeted radiation. And so then the field of Theranostics was then born. So if you can go on to the next scan, Michelle.
Well, hang on.
Yeah, so briefly, Theranostics uses this PSMA binding molecule, although they're developing other molecules for different types of cancers now. It attaches to the prostate cell anywhere in the body. And then what it does is it delivers its radiation payload. So the radiation they use now for Theranostics is a certain type. They're called beta and also alpha emitters. And these are specific radioactive isotopes that are very strong. They're very powerful. However, they can only travel very short distances. So they can't penetrate skin. They can't penetrate bones or organs or anything. They can only penetrate they can only travel a very small area. And because of this property, this is what the Russian assassins have been using, to poison their dissidents and different spies. And the reason they use these radioactive isotopes is because they can handle them. They can carry them around in their hand with no risk. They're not going to set off a radiation detector at an airport, but when they put it in the coffee or a drink or something that's ingested, then it goes in and gets transported through the body, and it kills the person from the inside out, because this radiation can travel a very small distance. So if it's in your blood, it can bind onto the blood cells and kill all the blood cells and get transported into your organs and kills all your organs. So with Theranostics, what they do is they attach it to the PSMA molecule, so it only attaches to the prostate cancer. And so it's a targeted radiotherapy, and it's an amazing tool. So if you can go to the next slide. So one of them is called lutetium-177. It's a beta emitter, and it's attached to this PSMA targeting molecule. And so most of the studies have been in very, very late stage patients with tumors all over their bodies. And, we've used it quite a few times. We've had, many patients get lutetium-177, and we've even had a patient get actinium-225. So another radioactive, there's a whole bunch of different isotopes now. So I'm just giving you two examples. They work incredibly well in late stage cancers, and they will eradicate all of the tumors in your body very quickly. Tumors do come back, but you can get repeat treatments of this because it's not damaging your organs. It's not like standard radiotherapy where you're blasting a beam of heavy duty radiation through your body. It's getting delivered to the prostate cells in a very small dose, and it doesn't affect other organs. So another one is using a new radioisotope called actinium-225. This is an alpha emitter. The benefits of the alpha emitters is that they do have a shorter range and they have reduced side effects. But importantly, you can use the alpha emitters after the beta emitters stop working. So you can use the beta emitters for a while, and then if they stop working, you can go to the alpha emitters. Another direction of Theranostics combines chemotherapy with PSMA targeting molecules. And these are called conjugate drugs now. So there's all kinds of conjugate drugs for different cancers. So, we're seeing a boom of different targeted chemotherapy. So that's what we call this, as targeted chemotherapy. So one classic example of this is docetaxel is a drug that they normally give you for prostate cancer, late stage. The problem is it kills all of the cells in your body as it's in there. And to give it in a really high level is going to be very toxic for the body. So with Bind 014, it's docetaxel particles that bind specifically to the PSMA molecules on your prostate cancer. So it's targeted chemotherapy. And so this is another form of Theranostics. So amazing technologies here, and there's many new technologies. I could talk for days about the different new conjugate drug technologies for different cancers. But we'll stick with prostate cancer now, and these are just some examples. So Michelle, would you like to take it from here?
Not necessarily.
Okay.
Thank you.
Great presentation. Thank you, Michelle. I haven't had a chance to view it, so this is my first time seeing it. And so I think she did a wonderful job here.
Oh,
So regardless of the types of cancers you have, it's really important that you understand genetic testing. And genetic testing is FDA approved. There's a couple of companies that have FDA approved genetic tests, such as Foundation One. If the FDA is approving it, they're saying everyone with cancer should get it. That's hands down. So if your doctor says, why, oh, it's not going to be useful for you. Oh, it's, I don't see how it's going to benefit you, or it's, it's a waste of money. They're not going to find anything. Can you go back?
Oh, sure.
I didn't do the ding. So if they tell you that, then they're going against the FDA's guidelines, and your response should be, well, the FDA has approved it for my type of cancer. And so obviously there's a benefit to it. And you can use the examples that we used earlier of BRCA1 mutations, of AKT, mTOR, PIK mutations, and the drugs that target them. There's lots of different examples. And that's just the FDA approved drugs. There's lots of off-label drugs that you may not know. I mean, you may have NTRK1 overexpression or mutations in your prostate tumor, which would mean NTKR inhibitors or ALK inhibitors. There's tons of different targeted therapies that could benefit you that you can find out through genetic testing and expression testing. So then personalized research has to be real time. You don't do your research and then get your genetic test. You do the genetic testing and then find out what you want to look at. And then you say, okay, I have an AKT so-and-so mutation. And so I'm going to press in the Google search, AKT so-and-so mutation and prostate cancer. And that will give you a huge list of studies of targeted therapies and drugs that will be beneficial for you. So get the data first, spend your money on the diagnostics, and then do your research. So targeted treatment plans, you want to have that well established. There's all kinds of problems with tumor DNA sequencing that you could run into. We'll cover that in a minute. And then there's also new technology called liquid biopsy, and of course, PET-CT, as we mentioned, the PSMA PET-CT for prostate cancer. And so liquid biopsies are a great new tool. And what they do is they identify the genetic mutations that are unique to your tumor. So they're only found in your tumor, and you determine that through tumor DNA sequencing. And then we can measure the amount of that genetic mutation and use it as a surrogate for tumor mutation burden. So in other words, or not tumor mutation burden, tumor burden, sorry. We can use it as a surrogate to determine whether your cancer is coming back or whether you're responding to a drug. So typically, if you start a new drug, your doctors will measure the size of the tumor, and then 4 months later, they'll measure the size of it again. If you're paying for that drug and you want to know if it's working, you don't want to spend 4 months on that drug and then find out it's not working. If it's not working, then all of a sudden your tumors have grown and spread, and you've spent all this money, and now you're just in a worse situation. With liquid biopsies, you can find out within about 10 days whether a drug is working or not. And if you're getting immune therapy, it's one of the only ways to tell if you're getting what we call pseudo progression or fake progression, which is something we can talk about in detail at a different time. So you could go to the next slide.
Sure. Dave, I do see your hand up. Can you make a note of your question and we'll answer it in just a moment? Thank you. Most certainly. The next slide. Okay, well, the next slide is just kind of running through a little more detail of these things we were just kind of talking about.
Okay, so we'll talk about it a little more.
Sure.
So yeah, as we discussed earlier, it's important to get a tumor DNA sequencing test that has a lot of coverage, and it covers the full amount of the genes. You want to test about 500 to 600 genes, typically. Some hospitals will do their own brief, what we call, targeted panels, where they'll just look at 1 or 2 mutations, and they won't look at the whole thing. So definitely, if you're going to get tested, get private testing. Don't go with any of the government tests or the hospital tests. They're just not there. They are expensive, but they're well worth it. So one of the problems, obviously, is the technology changes a lot. And while I do love the FDA approved tests, like Foundation One, they've done a wonderful panel, and Caris and these companies do great tests. One of the problems is you have to order them through a medical doctor. That's just changed. You used to be able to order these tests yourself, but now you have to be a medical doctor. And so therefore, it's kind of their way of targeting the medical system, and focusing on the medical system for genetic, or for purchasing the tests. If you get a research-based panel, then you can order that yourself. It's exactly the same thing, but it just hasn't gone through the FDA approval process. So I recommend a research panel, because research panels are able to adopt the latest changes in technology. So we just bought our own system, and our system, the reason we bought this is because it's a research-based test, and it's robotic. It does everything for us. So we can do 8 tumor samples at the same time and get our results in 3 days. And we don't have to wait for months and months. The other problem with tumor DNA sequencing is, in Canada, tumor samples are basically put in something called FFPE. It's basically paraffin and formalin embedded. And the time that it takes to put that into this embedment, in this block, it's called a tissue block, determines how much of your DNA is deteriorated. So as soon as that sample is out of your body, it starts deteriorating. Most pathologists and surgeons in Canada are not really aware of the technologies of genetic testing. And so what they do is they just want to look at the cells in a microscope. So they don't care about what happens to the DNA. So a lot of the samples, I would say about 40% or 50% of the samples that we send to Foundation One or any of these big companies fail. And then we have to get another sample. And that can take months and months. We have to order another sample, and that's a big cost too. And a lot of times these companies, even if it's bad DNA, they'll sequence it anyways and still charge you the full amount and just tell you, oh, well, it wasn't the best sample, but here's your results. And you have to pay anyways. So the technology has changed. Our system is able to be optimized for this bad DNA, so for deteriorated DNA. And it's a type of technology. It uses a chip-based technology that's able to assemble the pieces of broken, fragmented DNA. So you have a much better chance of having a sample. And so that's why we bought our system, is so we can, number one, we can offer our patients a greatly reduced testing cost. And then number two, we can access, or we can use samples that some of the bigger companies would have to throw away. Michelle, do you have any comments on that point?
Well, you were starting to go down that road with talking about the problems with the FDA approval, which is once you get a system or something approved formally, you can't change it without.
Exactly. Yeah. Sorry. Yeah. Great point.
So that's why, even though it's an excellent test, the Foundation Medicine test with the FDA approval, that's why it only looks at 350 genes when the most current tests look at 550 to 600. So all we've been saying so far really comes back fundamentally to, we've got to improve your diagnosis. We've got to improve the thoroughness and accuracy of the information that's available to you about what has caused your cancer, what's driving your cancer, and which treatments are going to be best for you. So we're going to talk about a few other types of testing now, and then we'll move forward with the live consult and question and answers. But definitely looking for ways to increase the thoroughness and accuracy of your diagnosis is the absolute best thing you can do for yourself if you want the greatest chance of success. So that's what I'd like to say about that.
Excellent point. And just to summarize what you're saying here is the private FDA approved tests can't keep up with the technology because they have to get a new FDA approval each time a new technology breakthrough comes. Whereas the research-based tests are always at the cutting edge of the technology.
Yeah.
Okay.
Did you want to talk about the RNA, the expression?
Yeah, so this is a wonderful new technology. We're so happy to have this. We've been using it for what? A little over a year now, Michelle, is it?
Yeah, about a year and a half is when
year and a half. Incredible technology. So this looks at the expression of the genes from a tumor sample once again, but it counts the amount of RNA molecules, and RNA are basically just the templates for the protein. And so basically it tells you how much of that gene product is being produced by the tumor cell, and it compares it to two samples of your normal tissues or of normal tissues, standardized normal tissues. And it says, okay, your ALK gene is overexpressed 200-fold. That means ALK inhibitors will benefit you. Or your, your RAS gene is, your KRAS gene is overexpressed, or your, mTOR gene is overexpressed, or your tumor suppressor genes are underexpressed. So a mutation typically causes a gene to be overexpressed or turned on permanently. So a mutation changes the structure of a gene so it can have different functions and have different functions that it was designed to do, and therefore they can be cancerous functions. And so tumor DNA sequencing looks at mutations. RNA expression testing just looks at the amount of that mutation. And this is really important because one of the things that happens in tumor DNA sequencing is you're going to get a bunch of mutations that are called variables of unknown significance. And these are mutations that happen in these cancer-causing genes, but they're unique to you and they've never been discovered before. And therefore, we don't know if they make the gene cancerous or not. We just know they're in your tumor. They could be benign mutations. They could be non-driver mutations, and we don't know. So they're just called variables of unknown significance. Well, the beauty of the RNA sequencing is it complements tumor DNA sequencing by telling us, yes, you have a variable of unknown significance in your ALK gene, but you also have 1,000 or 500-fold overexpression. So that's not a variable of unknown significance anymore. That's an activating mutation that is causing overactivation of your ALK oncogene. So it allows us to tell whether these VUSs are actually causing a problem to your genes or not. Additionally, the company we use has this artificial intelligence, and what they do is they look at all of the overexpressed genes in your tumor sample, and they say, okay, they match it against a database of drugs. And this database basically, so every drug is going to have a beneficial, it's going to turn on or turn off a certain set of genes in your tumor. So a drug like a chemotherapy drug, like docetaxel, will typically, let's say it's gonna turn down 7 pathways that cause tumor growth, and maybe turn on 2 pathways that cause tumor growth in your tumor. So the overall balance is 7, and then there's 2 that it causes the tumor to grow in. So every drug is like that. Some drugs more than other, but the effect of each drug on your tumor is going to be unique to you because the expression of your genes and your mutations are unique to you. So in one person's cancer, docetaxel may turn down 7 tumor-causing genes and turn up 2. In another person's cancer, it may turn down 14 tumor-causing pathways and turn up 7. So this artificial intelligence scales the positive and negative effects on your specific tumor of a massive amount of genes or drugs in this database. And so then it picks the best 10 drugs for you, and it scales all the other drugs in this Excel file. So you have this massive Excel file, and you can say, oh, well, you know, how's this drug going to work for me? Well, that's listed as number 167, you know, by the computer. Whereas this drug over here, that's for breast cancer, is listed as number 2. And so there was a clinical trial that looked at this, and they found significant benefits with this approach. So artificial intelligence, computer-based technology. Now, the problem with that technology is the database it uses of drugs is well established, and new drugs come out literally every couple of days. So in order for that database to be upgraded, which it is not, it's still a little old, they have to go through a rigorous process to make sure this artificial intelligence is actually doing what it's supposed to. So what we do is we take their raw data and we look up these new drugs and do a by hand analysis after the computer has done what it's done. So computers are stupid. They only do what you tell them to do, and they're not going to know that there's a new drug for ALK overexpression. So if we know there's a new drug for ALK overexpression, and we see you know, you have high ALK expression, we're going to recommend an ALK inhibitor. So yeah, I think that's all I wanted to cover so far.
You did talk about liquid biopsy monitoring before, so
Yeah.
I think we can move past that and go and let folks get some questions answered. And then if there's anything more you want to talk about with treatment monitoring, we can come back to it. Does that sound like a plan?
Yes.
Okay, so I think where are we at here? I'm always interested in this whole concept of pseudoprogression. But let's do what I said. I'm going to stop sharing, and we're going to do some live consults now, answer some questions, and then we can come back to this as time permits.
You bet.
Okay. Okay, so let's see here. I'm just going to use my powers. Let's see, cancel, allow participants to unmute themselves. There you go. All right, so I think I've just accidentally unmuted you, Alex. You should be able to unmute yourself.
Oh, thank you.
There we go. Yeah. So you guys all have the power of your own microphones. Please use it wisely. All right. So we have 2 folks who have sent their information to us to have you review, Alex. There's Dave and Stephen.
Okay.
I'm assuming you've got their info handy.
No.
Where do you have it? It was emailed to you. Where would you have it?
Oh, okay. My apologies. Let me access my email.
Please, yes.
I missed that. Sorry, it's been a crazy day. Okay.
I have it handy, but it would probably be best if you have it on your screen and you're snooping at it.
Yes. So can you resend me those right now, Michelle?
Hang on, folks. In the meantime, if anybody has a question, go ahead and unmute yourself. And
well, perhaps we could have the person themselves explain it instead of me reading over it.
Oh, sure. But
Would that be an option?
Dave, for example, sent a really excellent summary. I think you'd really benefit from seeing, and we have Steve's most recent test results.
Okay.
So I will go ahead and send that to you. Dave, how about you go ahead and unmute yourself, assuming all systems are firing and allow you to do so. And I'll just forward Alex the sheet you sent me again, so that he's got that handy.
Okay, yeah. Can you hear me?
Yes, I can hear you great. Hi.
Hi. I'll just wait till you get the email. It'll be a lot quicker, more efficient use of the time if you have that in front of you.
That's what I was thinking. Totally.
Okay, by all means, yes.
And for the record, this did go out yesterday at noon.
I'm sure it did. I completely missed it. I didn't know you were going to be sending these to me. I apologize.
All right.
Okay, and my email is pretty slow right now too. So
okay. Any other excuses?
Yeah, here we go. I've got it now. Okay.
Okay, and I'll
Oh
send.
boy.
Stevens
So
as
I'm
well,
not too
so
good
it'll
with
be right
technology,
there.
clearly. Okay. So you're okay talking about this then?
Yes, yeah, definitely.
Okay.
The more we
So,
can bring awareness of prostate
yes,
cancer, the better.
yes. So you're diagnosed with CLL
Yes, yeah, stage
and
0.
prostate cancer.
Yeah.
Oh boy. Okay. And so your Gleason was 4+4. Okay. And so you started on Zoladex, ADT. Great. And you had a PSMA scan in Vancouver. Yay.
Yes, yeah, as part of a clinical trial.
Yes, that's how it was given. Yeah. So you started on Xgeva. I'm not really good with the brand names. So Xgeva.
Xgeva is the one to make sure you keep your bone density.
Yes.
Yeah, I forget what the drug is called itself.
Xgeva. Yes. Okay. So Xgeva. Okay. Denosumab. That's right. I remember it now. Okay, great. Good on your oncologist for prescribing a bone modifying agent. There's also zoledronic acid, but Xgeva is a good one too. It's a rank inhibitor. What else do I see here? Zytiga. Zytiga is
That's the abiraterone.
abiraterone.
Yes. Yeah.
Okay.
I've been on that for about 9 months now.
Okay. Okay. How do you feel on that?
I mean, I've got fatigue and muscle loss over the last 3 years. It didn't just start with the abiraterone; it started with the Zoladex.
Okay.
So, yeah, but still functioning.
Yeah. So that's a steroidal inhibitor, androgen receptor antagonist. So you've had, so your PAC, it looks like you're responding really well. Had genetic testing. So you have a BRCA2 and a HOXB13 mutation.
Yes. Yeah.
So have PARP inhibitors been mentioned to you at all? Yes.
Well, I was on a clinical trial called the Magnitude one, which
Right.
is the abiraterone,
Wow.
prednisone, and possibly niraparib, which is one of the
Niraparib. Yeah, niraparib. Yeah. Wow. Well, that's great. I think you're doing amazing. I mean,
well, unfortunately, my PSA has been increasing. It initially dropped from 11 down to 3 last October when I started on the abiraterone. But now over the last few months, it's increased continually, and it's up to 21. And the most recent bone scan showed 5 new tumors on my spine and ribs and things.
Okay. So I would suggest tumor DNA sequencing, definitely, and expression testing. I mean, if that's your goal, or, just go straight for the Theranostics. Definitely. If you can go to Germany for Theranostics. Now you're saying that you're not eligible due to the CLL, correct? What is
there's a clinical trial in Vancouver with the lutetium 177.
Yeah.
But I'm not eligible because of the CLL.
Yeah. So you've been really on top of the technology here. That's great.
Well, I've done a lot of research.
Yeah,
I'm up at 3 a.m. doing this too.
Well, yeah, you could be teaching this seminar. That's
wonderful. No, not quite that level.
So I would like to see you try darolutamide with ADT, obviously.
Yeah.
And,
what about
docetaxel?
Pardon?
And docetaxel.
And docetaxel.
Yeah. So it's the triplet. So the clinical trial for darolutamide that worked really well included ADT and docetaxel.
So both chemo, the
AR antagonist and ADT. Yes.
Yeah. And
triple threat.
Where would I get that done?
Well, I would be pushing your oncologist. I know I spoke with an oncologist recently who said he's been able to get darolutamide and they're pushing it. The drug company's pushing it, and he's been able to get it for a bunch of patients. I would definitely upscale it from abiraterone. Now, one thing to consider too, because this is a bit of a bone of contention for me, is castration resistance is not something that occurs overnight. It's something that happens slowly. And obviously it's damage to the androgen receptors themselves. And it just happens, it'll happen in certain cells, but not all of them. So a lot of doctors will say, oh, you're castration resistant, cutoff value right now, we're taking you off the AR antagonist. And that's a big mistake, because then you're not dealing with all of the tumors that are still castration sensitive, or in the case of darolutamide, it works in castration resistance tumors and mutated tumors. So there's a lot of variation going on in those androgen receptors that can be addressed and targeted by doing something like darolutamide, chemo, and ADT. You're basically getting everything.
Yeah, they're definitely still keeping me on the ADT, on the Zoladex.
Yeah. Okay, well, that's good. Your doctor's doing a good job there. Now as far as CLL, what's your status of it?
Well, I'm stage 0, so no real.
I'm sure it wouldn't be a big issue. I would go to Germany for Theranostics. I would try the darolutamide triplet combo, and then I would go to Germany for Theranostics, starting with the lutetium and then move to the actinium.
Okay, I've got my next appointment with the oncologist in about 2 weeks.
Okay.
And they're trying to decide on the next treatment, and really what I'm kind of hearing is likelihood of radium-223 or chemo, which would be the
docetaxel.
Yeah.
Yeah.
What do you think of that?
I would go with the ADT, darolutamide, and docetaxel.
Okay. How am I going to convince my oncologist to be able to do this?
Well, the data is really good. From the
Interrupt
trial.
there. The right answer, Alex, is Alex will help you.
We can try to help you. Yes,
that is exactly why we're here.
Yeah.
So if you've got your meeting in 2 weeks, we can most certainly get your medical records, and Alex and his team can have a review and draft a report for your oncologist and give it to them before your next meeting. So by all means, if you want to tackle it yourself, you've obviously come a long way.
Yes, definitely.
But certainly, if you just, if this isn't your wheelhouse necessarily, although you've been dealing with it for quite some time. So certainly Alex and his team within 2 weeks can prepare a nice argument for
what I would suggest doing is maybe just getting you a different oncologist. I mean, your oncologist sounds really good, but if your oncologist is not open to this or doesn't want to do the paperwork for darolutamide or doesn't, really feel it's going to benefit you, you can consider getting a different oncologist, like a community oncologist. I know some good community oncologists that, they'll do what you ask them to do. The problem is you may have to pay for darolutamide out of pocket. I think I'm seeing more and more patients get it though.
No, I'm not. I shouldn't say that he's going to be resistant. I don't know at this point.
Yeah.
Okay? Right. They've been very open to me getting, genetic testing, doing the PSMA, things that I've suggested.
Yeah, that's great.
So I'm not saying they're going to be opposed to it at this point.
No, Dave, our rule of thumb is let's change as little as we possibly can for you. So we always want to start by assuming exactly what you're saying, that your oncologist is going to be open to the most current medical science information. And let's just get that in front of them and see what concerns or questions they have, see what we can do about that. And then if that's still a no and you'd like to go for it, then there are other oncologists in your area we can connect you with.
Yeah, I'm over in Victoria, just for your information.
Sure. Andy, did you have any other questions at this time?
Oh, yeah, actually I did from earlier, the one on when he was mentioning about the liquid biopsy.
Yes.
Is that measuring the circulating tumor cells?
No, it's measuring the circulating tumor DNA. The circulating tumor cells technology is just not there yet. The problem is in order to determine, so what's important about detecting a tumor cell is detecting a stem cell, because they're the only ones that can metastasize. So we're not able to do that. What what they do right now is they use a bunch of different cell surface markers that that are typically overexpressed in cancers, but the problem is they're also expressed in normal cancers or normal cells. So they're not a guarantee it's cancer. With the tumor DNA liquid biopsy, we're basically looking at mutations that we know only occur in your cancer, and because we've done the genetic testing for your cancer. So we know that this KRAS mutation is only in your cancer cells. So we're able to use it as a surrogate for liquid biopsy testing.
Another thing, Dave, you sometimes because of Alex's expertise, he gets very specific about things. There's a difference between the type of tests that he's designed and uses than circulating tumor DNA, which might have been what you were asking about.
No, I think he was asking circulating tumor cells.
Cells, yeah.
Okay.
Because that, as part of the clinical trial that I'm on, the magnitude one, they measure that, but they couldn't do that with mine because of my CLL. That's why I was wondering about that liquid biopsy.
Yeah, interesting.
Yeah. Another question. So I was on this trial and potentially had the PARP inhibitor.
Yeah.
But I'm pretty sure I ended up with the what's the word I'm looking for?
Oh no, the placebo.
The placebo, yeah. And
Oh.
my doctor suspects I also am. Now I'm going to be going off that clinical trial because when you have 2 or more new tumors, you're no longer eligible for the trial. So I've asked.
They don't do a crossover?
No, not that I know of. Not on this one. They don't. But I have asked that I want to find out if I was on the placebo or not. So the question I have for you is there another way to maybe measure if a PARP inhibitor would be useful, like Olaparib or something?
Well, do they give you a pill?
Yeah, oh yeah. I have the pills.
Okay, so you can send that to Victoria. There's a mass spec lab and they can tell you exactly what it is.
Oh, I like that.
Yeah, it's about $1,000 or so. We do this a lot. I'm totally against closed label trials. I think it's ridiculous in this day and age, they're still doing that. There's really no purpose for it. If you do proper genetic stratification, I just can't believe that the doctors are actually suggesting this for people. You need, someone with cancer needs to know they're going on the drug they're taking, and there's no reason to keep it covered.
Back to that liquid biopsy, the liquid biopsy monitoring is a tool you can also use.
Yes.
To determine whether what you're taking is actually working. And that would be another way, but first and foremost, of making sure your treatment is working well, but also another way to assess whether you're on a placebo or not, to a certain extent, because it's just measuring that ratio of those live cancer cells in your blood. And if it's not changing and you're on this drug and other folks are getting a benefit, then there's a probability.
Yeah. The problem with your cancer is it's a bit of a black box. We don't have any genetic information or any expression information. Just that you have a BRCA and HOX B13. Do you know which BRCA2 mutation you have? Do you know what kind it is? Is it a?
Yeah, I think it was the BRCA one. Let me just see. 2, BRCA2.
Yeah, what mutation is it? I mean, there's many types of mutations that have different impact. So it can be a truncating mutation that basically stops production of the gene itself.
I'm not sure of that.
It should say on your pathology.
Yeah, I'll have a look at the genetic report that I got.
Okay. Great.
So then kind of back to that question. I'm assuming the triple combination one potentially has a reasonable amount of side effects, whereas the PARP inhibitor, if assuming it's useful, would have less side effects and maybe even be more targeted to my mutation.
Well, you have to understand at this point in time, you've probably got a lot of heterogeneity. And we don't know what mutations you have that would prevent that PARP inhibitor from working. So, without having a full genetic information, it's really hard to go with a single agent targeted therapy. I wouldn't want to spend time on that right now. I would really tend to focus on doing something that's going to be more inclusive.
Okay, thanks.
Okay.
Thank you,
You're
Dave.
welcome. Yes. And so we have something for, did you send it?
Yep, I emailed it to you. So Stephen's going to, he's next up.
Okay.
And then Jeffrey has some
Okay.
questions about his case he'd like to ask.
Okay, so I'm seeing medical records here. Okay.
Yeah.
But there's not a summary for Stephen?
No. So
Stephen, would you be prepared to talk about your case a bit?
Sure.
Okay, great.
Yeah. So about 8 months ago, after having an MRI with a suspicious 7 mm lesion,
Okay.
I had a biopsy, which showed a 3+4.
Okay.
With a couple areas just on one side of the gland.
Yeah.
That had cancer.
Okay. So, okay, 3+3 grade, 25% of core area. So on the left side, and then you got a 3+4 pattern. Okay. Do you have any other health conditions?
No, I have had some microscopic colitis.
Okay.
I had it 10 years ago, and then about 4 months ago, I had another episode.
Okay. Okay, so I would say get that prostate out as soon as possible.
Does that look like an aggressive cancer?
It's really hard to say without the genetic testing. I think it's just best to get it out now and then do the testing on it and see, because it could be upgraded to a more aggressive one once they take a better look at it. It's kind of hard. The biopsy cores are very thin and very small, and they're not really a good representation of a tumor. As you can see, you've got one biopsy core that's 3+3 and the other is 3+4. So I would definitely get surgery if I was you.
What about since it's on one side?
Yeah.
What about the targeted focal therapies?
You mean like a targeted like brachytherapy or radiation?
Well, that right now they're saying me to a radiation therapist to discuss that. But I was actually thinking of things like what Dr. Klotz is doing at Sunnymead.
Okay. Yeah, I'm a big fan of getting it taken out because have you had a PSMA PET yet?
No, I haven't.
Okay, well then I would get a PSMA PET first to ensure you have no metastasis.
Yeah.
I think that's very important. And if you really are set on preserving your prostate, I would probably want to take a closer look at it. I'd want to look at the genetics of those cores if possible. But personally, I am not a fan of leaving tumors in. The reason is tumors release something called exosomes. And exosomes are little membrane-bound transportation bodies that contain the genetics and the mutated DNA and RNA and proteins that the tumor needs to metastasize. And these tumors spread these exosomes out throughout the body, and they can seed and set up other sites of metastasis. They can also get taken up by normal cells and convert those normal cells into tumor cells elsewhere in the body. So you want a tumor out, and you want to get as many of those tumor cells out as possible. Radiation therapy may kill 99% of them, and you may be good for a while, but if that 1% is still there, that's going to be a problem.
Right. Well, after I, that's what the surgeon said. And then I did see a second oncologist who said, let's get you the gallium scan and then we'll talk.
Yeah. Okay.
Well, 6 months later, I was turned down for the gallium scan.
Right.
I went back to that doctor and he just retired. so I never got the benefit. I think you know who I'm talking about now. So I
Yes.
never got the benefit of
Right.
his
Right.
advice.
Yeah.
And I got passed on to now a younger oncologist who said, "Oh, I think brachytherapy is a great way to go." So that's,
Yusuf, is that Dr. Yusuf?
yes.
Okay, he's really good. Definitely. I haven't worked a lot with him yet, but definitely he's a really smart doctor. And statistically speaking, he's correct. Brachytherapy is definitely really good. But I just don't like the idea of leaving a tumor in, and I'm going to have to agree to disagree with his assessment there.
Okay.
I mean, you know, he's definitely a great oncologist, and he's practical, but you know, when you have that surgical material, then you've got something you can look at further. You know, you can do the analysis, you can do the different tests and so on. And I think in someone like you that's fairly early stage, you know, I would be very aggressive in your diagnostics right now and your treatment.
Mm-hmm. So I'm hearing a couple of different things. I'm hearing, like, for example, what you're saying. I'm hearing what my GP says, because you have an aggressive cancer, you've got to do something about it. I've also gone to a holistic counselor who then put me in touch with a naturopath specializes in cancer. And he said, "Stephen, this is a very slow moving, take your time, maybe 1 or 4 years, you'll need treatment." So I, you know,
he can't say that off the information he has. There's just no way. You can't make those sort of assumptions. I mean, yeah, it may be slow going. You know, it just may be, but do you really want to take that chance?
Yeah. Now,
I mean, it's like driving to the store without a seatbelt.
Okay. Now, you mentioned about PSA. My PSA had gone up to about 5.5, but
Okay.
But since that time, you know, I've gone to a plant-based diet
Yeah.
and taking supplements.
Okay.
Subsequently, 3 months later, my PSA was 3.5.
Great.
But should I take away anything from that, or does that mean anything?
No, definitely. There's lots of things that can affect PSA. Does it affect the growth of the cancer? It's another issue. You know, PSA is not always just the growth of a cancer. You could see PSA going up and down. Your PSA is fairly low right now. Now's the time to strike. In my opinion, if I was you, I wouldn't wait any longer, and I would get that out as soon as possible and still get a PSMA scan. And even, I mean, put it this way, if you have metastasis, they're not going to spend the money on taking it out. So if you get a PSMA scan now and it shows metastasis, they're probably not going to take the prostate out, which is not a good thing, because even if you do have metastasis, you're going to want to have it out. It's a cost-saving thing. Typically, they don't do surgery on metastatic disease in Canada because it's not that beneficial, or, you know, cases are not that beneficial, and sometimes it is, sometimes it isn't. You know, it's my job to be the negative naysayer and prepare for the worst case scenario, because that's what I hear every day. I have no shortage of people saying, "Oh, I was told this and this, and I did this and this and this, and then now it's back. I was told I would never have it back again. I was told I was cured." I get this every day, all day long. So for me, your best option is to get it out and then do the PSMA scan. And then if you do have any metastasis elsewhere, obviously you're going to have to go on something, but at least you don't have the prostate there sending out signals to these metastatic places. I think that's really important.
Okay, thank you.
Do you have concerns with surgery?
Yeah, when I read about it, it doesn't seem very appealing.
Yeah, I mean, it really depends on where you go. You want to get surgery at a major center. You know, the larger the center you go to, the less complications you're going to have. And if you go to a teaching hospital like VGH, you get the robotic surgery, make sure you tick that little box that they tell you to, or that's in there that says, "I only want the professor or the teacher doing the surgery," because I missed that box. And when I went for my surgery, they slashed an artery in my kidney, and I ended up losing part of my kidney for something that was totally avoidable. I just didn't tick that little box because they had me sign the papers just as they're wheeling me into surgery. So you make it very clear, if it's a teaching hospital, and a lot of places are teaching hospitals, you make sure that the teacher is doing the surgery and not the students.
Stephen, is there are other reasons that you might want to hang on to your prostate? Is that part, is it the surgery that you're a little concerned about?
Yeah,
or
I guess I haven't really had any surgery, so the idea of losing part of your body, even though it's a small part, that is not appealing.
No.
That the idea that maybe I could do some focal treatment and still preserve some of it seems more appealing.
And that may be the case, but do you want to take that chance? Do you want to risk it when you have an opportunity now to make a huge impact?
That's, yeah.
I mean, this is your decision, obviously. I think you need to really seriously think about this.
Yeah. It's not easy though. And certainly, in the medical system, things like surgeries are often tossed about fairly cavalierly. And I do appreciate what you're saying, Stephen, about just the reluctance to lose a part of your body and just to go through that whole process if you don't need to. And I guess, what we're trying to say here is if you have a chance to get the cancer out, that's the best thing you can do for you. And then, of course, following up with the proper testing to make sure you know what was happening there. And if there are metastases or if there is a recurrence, then you can hit the ground running with the proper treatment right away.
Exactly. We have a good friend that just recently had prostate surgery, and he elected to get it out. And his disease is done. He's cancer free. He's enjoying life. And he said it was nothing. He said it was easy. He had robotic surgery. And the robotic surgery doesn't take very long. The recovery is really quick with robotic surgery. And he didn't get any negative side effects whatsoever. So, they do these surgeries all day long. If you go there, it's like, take a number. And he was in and out of the hospital very quickly. I had a complication because I didn't get the doctor who I was hoping I would. I got a student who had probably never done it before. And that was my problem. And just because I didn't sign the form properly. So definitely, it's probably not going to be a problem. Now, if you're in some small town somewhere in the prairies or something, I would say, okay, you may want to go to a big city center like Toronto or Montreal or Vancouver.
I'm in Vancouver, so.
Yeah, so I'm sure you'd be fine here.
Okay, thanks, Alex.
Now, you'd have to push to get it done too. It's your decision, but I really would push for that.
Well, they did put me in touch with the surgeon, the top guy who does the open surgery.
Right, okay.
At the cancer clinic. That was the first person I talked with.
Okay, yeah.
It makes sense that you're looking for options.
Yeah, definitely.
See what you can do to
Definitely.
avoid that outcome. So hopefully we haven't added more stress and confusion, but helped to clear things up a little. Do you have any other questions, Stephen?
No, that's good. Thank you.
Okay, thanks. Jeffrey, you should have the power to unmute yourself.
There we
There you go. Wonderful.
got it.
Hi, Jeffrey.
Hi, Alex. I've was diagnosed in March of 2019 with an intermediate prostate adenocarcinoma, and then went with an ultrasound on March 29th. I guess prior to that, a PSA of 12.1. Then urine chemistry, cytoscopy, biopsy in June of 19. The tumor was primarily in the left lobe with Gleason score of 7 out of 10, 4+3. And then nuclear bone scan in July of 2019. No evidence of active bone metastasis.
Okay.
Things showed up like left wrist degenerative change and spinal scoliosis. So two separate urologists wanted to remove the prostate, seminal vessels, and surrounding lymph nodes.
Okay.
In September 16th, 2019, I had a prostate with contrast.
Okay.
And Seminal vessels, normal. Lymphadenectomy, none. Based on size criteria, prostate gland 5 by 3.3 by 5.1 centimeters, 43.8 cc's. PSA density was 0.28 based on a PSA 12.1, but by August the 16th, my PSA was 7.5, and I calculated the density as 0.17 based on 7.5. And then saw a radiation oncologist in November of 19. He wanted to irradiate the prostate. The bright light was for me, and maybe not since listening to you, maybe it's not such a bright light, that he gave me options to include active surveillance.
Right.
And that's what I chose, active surveillance. And I've worked with, I'm still working with one, but I've worked with 2 other naturopathic oncologists. The middle one retired from Victoria, and he was treating me with remedies, nutraceuticals, and different remedies that he you probably know who I'm talking about. He's written the book on it. He's been in it for years, but he's just retired last October. And so my PSA this last month on the 26th of August, it was up a bit. It was up to 8.2. But if I look over the last 18 months, 5 of those months were in the 5 range, and 4 months were at flat 6. So that gives me over an 18-month period. Maybe you can't do it, but I just worked an average of 6.22, but I don't know if that means anything or not.
Yeah, I don't really like to go with just PSA. I think it's really important to get a PSMA scan, regardless of who you are and what stage you're at. If you have prostate cancer, get that full body PSMA scan. It's not worth missing something.
And actually, the oncologist who just recently retired at North Van, that's what he had suggested. But I don't know if it's available in Vancouver.
It is.
Yet.
Yeah, it's available at Initio in Burnaby.
Initio, okay, yeah,
Yeah,
that's who he had mentioned. But since he was retiring, I saw him in. I last saw him in July, I guess, and it was an 8-minute visit. He wasn't invested, he was already retired, basically.
Yeah, I know.
So the comparison MRI I have, the first one was done September 19. The next one was done November 2020, and the prostate at that point was down to 39 cc's. On the 2019 one, there was a 1.8 cc PIRADS 4 lesion in the left base and the midland peripheral zone.
Okay.
And a 0.2 cc PIRADS 3 lesion in the left midland and anterior zone. Now in 2020, a 0.1 cc lesion in the peripheral zone on the right side, which was new since the last study. The PIRADS, the one in the left midland, was at this point only 1 cc's, but it's PIRADS 5, whereas it was
okay. So I think we're seeing a bit of a theme that the watch and wait is not working.
Is that right?
That's what it sounds like to me. If you're getting new sites.
Well, the one disappeared. There was a new one, a 0.1 cc on the right side, but the lesion described in 2019 in the left midland and anterior zone on September 16th, 2019 examination is not seen with any certainty in November 12/20.
What type of scan was it?
MRI.
MRI.
Okay. So did they say anything in the MRI about positioning and body positioning, and whether it could have just been, sometimes these sort of things happen with MRIs?
It was done at the same facility. In the big picture, I'm not really happy with that facility, like Falls Creek, because it took me months to get a comparison out of them, and it was just really difficult. But
I would really I'd go for the PSMA PET. Why mess around?
Yeah. So
it's just not worth it.
Again, I've been forwarded on Dr. Youssef, and I have a consult with him next month.
You can just get a PSMA PET. You can download the form off the website from Initio, and then just go to a GP or a drop-in and just say, here, sign this. You know, sometimes as a form, you can do online doctors. They got online doctors that can sign the form.
It's easier than that, actually. It's just Alex is so in the lab, he might forget that we actually provide this as a service for people. So
Yes.
We can certainly help coordinate this for you and make sure the referral gets signed and you get your scan. PSMA scans are usually within 2 to 3 weeks, assuming all machines are firing on all thrusters, and it doesn't take that long to get a scan happening for you.
Yeah.
So that would be one way. And they, yeah, I'll just leave it at that. So if you want our help, you can let me know, Jeffrey, with that. But I guess what Alex and I are both hearing and a bit concerned about is, while of course it's right for you to be feeling some hope and some positivity about the fact that one lesion seems to be smaller, not quite as present, not quite as defined. The fact that there are new ones is what we're worried about for you.
And just, I just think that the imaging modalities are not that great. As we went over the statistics early, PSMA PET is 92%.
Yeah.
It's still going to have 8% false. It's going to miss 8% of those tumors, but hey, that's a lot better than the other imaging modalities. So, I mean, use the best you can.
So when I'm, and again, I did the math, like between 2019 and 2020, those 14 months, it looked to me like there was a 45% reduction in the main tumor because it was 1.8 cc in 2019. And 14 months later, it was only 1 cc. So is that false to look at it that way?
Well,
it's just not that. What we're trying to say is the statistics show it's just not that accurate. So if we could say that is 92% accurate, we'd feel a lot better on your behalf. But 2 scans together it takes to get to 65% accurate. So that's the concern.
Yeah. I would start with the PET.
Yeah.
There's no reason not to.
Yeah, the goal, yeah. It might sound like we have shares at the PET CT clinic. I just
We
want to
don't.
tell you, we don't make any money off the test we recommend. We're not, while we have affiliations so that we can get our clients in quickly. The benefit is to you of having the most accurate assessment. And if the PSMA scan comes back and it looks good, then you can continue to do this active surveillance. Exactly. That's what feels best for you.
Yeah.
Well, Dr. Klimo did recommend the PSMA, but he didn't make me aware that it was available at that point. But it
wasn't available at that point.
Yeah,
it really is new technology, so it really is. So it's just been available in Canada about 6 months now.
Well, no, it was available initially at a few different places, and then basically they couldn't get the isotopes, and now they got the isotopes again. So it's happening now again, and there's a lot of confusion around it. But this particular facility, Initio, has gone through a few different ownership changes, and so they just replaced their scanner. And so during the last few months, it wasn't available, and I believe now it is.
So can PSMA PET can the previous 2 MRIs I've had, can they be of any use to compare against the PSMA or not?
I would use the PSMA as the baseline.
Yeah.
I would start with that.
Okay. So anything else that may be relevant? I've had lifelong sleep issues, and I recently learned probably earlier this year that I have mycotoxins.
Sorry, you have what?
Mycotoxins.
What are mycotoxins? I'm not aware of those.
I have fungus in my body.
Oh, really?
Yes.
Okay, and is that being treated properly? Now, who discovered this? Was this your naturopath that discovered it?
Yes.
Okay, I would be a little wary of that diagnosis.
In terms of?
In terms of naturopaths are not doctors. I don't.
Well, I did get sent away a test.
Yeah, I would get that confirmed through your GP or a
Allopathic physician.
college registered specialist, an MD, not an ND.
Okay, my GP, I don't know if she would even be capable of it.
Yeah, well, you see, the thing is the naturopaths kind of offer tests that can't be confirmed or not confirmed by standard medicine. And that's kind of what they do. So, you can't really dispute them because, there's not really a test for that.
I think we should probably not say anything more on that specifically because it's not something you're familiar
Exactly.
with, Alex. Maybe
No,
you
it's
want
not.
to do a
No.
little.
I would like to add, though, that I've had the house tested and there is mycotoxins in the house.
Okay. Well, I would really speak to your GP about that. And if they don't want to do anything, get them to send you to an infectious disease specialist because they have the tools of the trade.
Yes. And remember that right now in Canada, not just because of COVID, it was this way before, but it's a little worse now. To see a specialist can take a very long time going through standard channels. And sometimes that's just the way it is and how it has to be. For the most part, there are ways to expedite things depending on who you know and also if you're willing to pay. So any of the things we're talking about, can be accessed more speedily and from numerous different facilities globally, if you're willing to pay. Really, it comes down to that.
Yeah.
So what I'm trying to say to you specifically, Jeffrey, is if you strike out with the GP in terms of this, or the visit to the infectious disease specialist is like 2 years away, don't feel like you have to wait for that. There are options. The other thing I do want to say just to everybody, because there are, it's natural to want to do integrative approach to cancer care, and we support that, just to be clear. There is evidence to certain things that integrative practitioners provide, which is why it is advancing as a school of medicine, but there's lots of things that naturopaths provide that don't have a lot of medical science evidence, peer-reviewed studies, something reproducible, some mechanism that we can say, oh, okay, I understand how this mechanism works and I can see how this would be helpful. If you want to check in about any of these things, a great resource is PubMed, PubMed. Just like published medicine. So PubMed, it's the National Institute of Health website where they post, it's quite recent, quite current information. And so if you just Google PubMed, PubMed, and just keep that in an open window there. And anytime you hear of anything, go there and look there, because what you'll see is the most current, well, you'll see all that they have of the actual studies talking about this particular thing. And all you need to do essentially to get started at least is read the abstract and see, does it say this no clinical evidence shown, or warrants further study, shows promise, things like that. If you don't see the thing you're looking for in PubMed, it probably hasn't had any studies done at all of any merit. And so that's kind of a nice little check for you to see, like, where is this in the queue of things that actually have merit, that have been vetted, and that will allow you to have more trust in your next steps.
So would I look up mycotoxins on PubMed?
That's what I would do if I were you. I would look up all of those things that are being recommended to you, and you'll see that some of them almost certainly will be there, and there'll be some support, and others may not be there. And if you can't find it anywhere else, again, a good statistical resource, it's probably something that you want to imagine is at best having a placebo effect for you.
Now, I do want to say something though. Diet, don't ever underestimate the importance of diet and exercise in regards to cancer. I mean, I did a lot of graduate study research on that. And this is something I've been doing for a long period of time. Huge impact, sometimes as much as the treatment. There's all kinds of things like, green tea, for example, could reduce PSA. And, we've seen green tea. We had a case where we had a patient who was drinking green tea, and they had 8 tumors in their prostate. And after 2 years of drinking green tea every day, all day long, now they drank a specific type that had been used in a clinical trial and was tested for a high level of EGCG, which is the active ingredient in green tea. And they actually had all of their tumors disappeared. And I didn't believe it. So they sent me their medical records, and I went over it, and sure enough, that was the case. Now, obviously, you want to know the genetics of a situation like that. You don't want to just be throwing some sort of thing at something. You want to know that there's overexpression of PIK signaling and AKT signaling, which is what the EGCG targets. You don't just want to throw something at something blindly like that. You want to use the science that is available there. So things like curcumin, EGCG, resveratrol, all can reduce cancer growth to a certain degree. And the way they do that is by reducing inflammation. Inflammation is a huge, powerful feeder of cancer. And anything you can do to reduce inflammation, even a daily baby aspirin can have a 5% reduction in death of prostate cancer patients. So daily aspirins. Exercise is huge. You want to be doing weight-bearing exercises at least 3 to 4 hours a week. You can significantly reduce cancer risk. And when you have cancer, you can significantly reduce the ability for it to spread. One of the reasons, as I mentioned, is other cells in your body compete with cancer cells for resources. One of those cells is muscle. So muscle competes with cancer cells in a variety of different ways. One of the ways it does is through a process called angiogenesis. So cancers use the recruitment of blood vessels through a process called angiogenesis. It's an incomplete process. The actual process that muscles use is neogenesis. And so angiogenesis is missing the last step. And what happens there is you end up with leaky blood vessels that are perfect for tumors, because then they can spread their cells throughout the blood vessel system, because the blood vessels leak. So when you lift weights, there's a limited amount of resources and hormones for blood vessel creation, and your muscles preferentially steal them from the cancer cells and limit the ability of the cancer cells to get their own blood supply. There's a multitude of different factors with weightlifting. There's just a muscle that is contracting produces a protein that reduces cancer, many different cancers. There's a multitude of different factors there. You're increasing also your lymphatic system is moving. You're circulating your immune system throughout your body. And then, of course, when you lift weights, what you do is you tear the muscles. And those muscles are repaired by a set of processes that cancer cells would normally use to grow and metastasize. And so there's a multitude of benefits. And we see this over and over again in clinical trials and studies. And then high amounts of fiber. So we spend a lot of time researching the biota. For example, in breast cancer, there was a recent study that showed that when women have a combination of soluble and insoluble fiber and either kefir or Greek yogurt, which is considered a probiotic, the fibers are considered prebiotics because they provide a molecular scaffold for these certain bacteria. There's a class of bacteria called Immunotherapy that grow in the distal colon. And what they do is they produce these long and short chain fatty acids that actually activate an arm of the immune system called the gamma delta T cells. So normally the gamma delta T cells occur at a very low rate. They're about 3 to 5% in the body. But they are a unique type of T8 cell that attacks tumor cells without needing to be activated. And when you have a lot of fiber and probiotics and prebiotics, this allows the Immunotherapy and many other bacteria species, is like literally hundreds of them that also grow on the scaffold of fiber. And they produce these long chain and short chain fatty acids that activate these gamma delta T cells. So in a recent study they did, I believe it was Mayo Clinic, the women were on chemotherapy. They had estrogen positive breast cancer, and there was a 30% reduction in the amount of metastasis to the lungs in these women who took that compared to the placebo. So definitely a healthy vegetable-based diet, which is heavy in fiber, fish, avoiding land animals, have a steak maybe once a week or something, but heavy cold water fish and high fiber diet is really important for most cancers, and creating the biota that shuts down a lot of these signaling pathways that are involved in cancer. I mean, I could talk about this for hours with you, the individual pathways. It's not a cure. It's not to replace therapy, but you want to do everything you can, regardless of the impact, even if it's only a 1 or 2% impact on reducing your cancer spread.
So I have completely changed my diet. So as far as diet goes, I just eat fish and
Wonderful.
salmon or
Excellent.
cod or haddock. And then I eat cauliflower and broccoli every day.
Wonderful. So maybe you are getting some reduction then, you know?
I think so. And in the morning I have berries, and I have
Excellent.
10 tablespoons 10 tablespoons of seeds on there soaked in soy milk.
Excellent. Excellent. You're doing everything I would recommend there.
Now, and I went to the gym for 30 years, from age 40 to age 70. And then cancer came up, the pandemic came up, and I ended up losing a total of 40 pounds. I've gained about 10 back now. And that was because I was told to cut back on the metformin. I was taking metformin 500 twice a day. So
how come you're taking metformin?
It's in clinical oncology. It's in the COC protocol.
COC. So were you on the COC protocol?
Well, those things came from Dr. McKinney, the metformin, and also naltrexone 4.5 milligrams.
Good. Yeah. Very powerful anti-inflammatory. It has anti-cancer properties. Definitely. You know, all of these things have an impact. The COC protocol, it either works or it doesn't. It was developed in Germany a long time ago for brain tumors. They got some patients responding it to others that don't. A lot of our patients go on it. It really depends on the molecular basis of your cancer. Metformin is an mTOR inhibitor. So it targets that pathway that I said is expressed earlier on, the mTOR pathway. So metformin is a natural mTOR inhibitor. And it also reduces the need for insulin. So that's important. Cancer cells love insulin. Another approach you want to take is daily aspirin. I'm sorry, I mentioned that earlier, but statins,
baby aspirin, right?
Reducing cholesterol is really important. Having is a small amount of cholesterol. You want your cholesterol as low as possible. Beta blockers reduce cancer spreads. Statins. So, you know, these are things that most people can take to reduce the spread of their cancers, but these are really effective in prostate cancers. You know, they're not treatment, but they're part of integrative therapy. So if you are going to do integrative therapy, use science-based integrative therapy. Get it off PubMed.
In terms of supplements, you know, I take about 60 pills a day.
Okay. So if you do take supplements, there's been many studies, there's consumer testing, that the vast majority of supplements not only contain not what they propose to contain, but they also contain some dangerous heavy metals and lead and cadmium and things that actually are carcinogens. So if you do supplements, go to a site called consumerlabs.com. They are an independent testing lab. And what they do is they go into stores, they buy vitamins and supplements and green teas, and they test them and they look at them, and then they report on their website what they found. And then they'll provide you links to the ones that pass their scrutiny so you can get them for a discount.
I don't buy supplements at the health food store.
Get them through consumer testing. I was quite surprised because one of the best olive oils and one of the best forms of curcumin was actually from Costco, but it was only a certain brand that they sold. So definitely, if you're going to use supplements, only use tested supplements, because some supplements are really bad. And in fact, the ones that the naturopaths that sell in Canada, the naturopath brands, 9 out of 10 of those contain cadmium and dangerous toxins. So there's been lots of independent testing on supplements. There's no regulation of them. So only use supplements you get that have been reviewed through consumer labs.
And I guess I have to admit that the stuff, the NFH stuff that I've been taking, and I buy it directly from NFH now, that was as a result of Dr. McKinney's recommendations, what he did. So additionally, I do take 6 ounces of pomegranate juice every day, along with unsweetened soy beverage and
Wonderful.
a teaspoon of Matcha green tea.
Nice. Matcha,
along
matcha's
with
got a
protein powder.
Yeah. Good. It sounds like you're on a really good diet plan right now for your type of cancer. That's great.
Yeah. But
So
still,
get your PSMA PET, and then I'll be happy.
If I could get better sleep, but sleep for me has been a lifelong issue, and I believe that started around the age of puberty when I had a serious concussion.
Oh, yeah, I understand. I'm lucky if I get 2 hours sleep a night too. I'm always tired. I take a nap in the afternoon to compensate, but you know, it's
But
it's
you're
tough.
right to think that, Jeffrey. Certainly a brain injury can definitely affect your ability to get restful sleep. Sure. Yeah. And I do just want to sum up what Alex was saying about the supplements. Obviously, there is some good clinical data, and again,
Yes.
back to mechanisms, some well studied and defined mechanisms that make certain supplements, we'll say, proven to directly influence cancer, like curcumin, you've heard of, I'm sure, like
I'm taking it, yeah.
Yeah, like the EGCG and you know, a couple of others. So and yes, unfortunately, there isn't a lot of regulation in the industry. So overall, we are in full support of supplements, assuming there is a proven mechanism and that there is a consumer report indicating that this particular brand has in it what they say they do. So with those extra caveats, which make all the difference, because what would be the saddest is for people to be taking all these pills and going through all this process and having it affect them not at all. So if you're going to go through all the cost and trouble of these supplements, let's make sure they have a proven mechanism and that they actually have in them what they say they do. That's all I want to say about that.
So additionally, I for about 18 months or so, I've been taking a cannabis suppository every night. For the, pardon?
CBD?
Well, it's got a lot of CBG in it too. It's got frankincense in it. It's seems to be a pretty good. I get it supplied from the island, and it seems to be a pretty good. And recently, he just got an incredibly stronger CBG than he previously did have in it. So
we're back to check PubMed. What does the data say?
Yeah.
There's
not a lot of positive data on you know, marijuana products in regards to reducing cancer, but it's got lots of other benefits for cancer patients and anyone who wants to use it. And you know, I mean, you know, it stimulates appetite, relaxes people, gives you a better, you know, headspace in many occasions. So there's lots of positive benefits to it, but don't be fooled into thinking it actually has anti-cancer property. It's probably no better than, you know, salad or something.
Well, when I take it as a suppository, I don't. I mean, there is quite a bit of THC in it, but I don't feel it at all.
Oh, interesting.
You know,
okay. Maybe you're used to it.
Well, it you know, it bypasses the digestive system.
Right. Yes. Yeah.
So again, the whole point is, if you're going to go through that process on a daily basis, let's make sure that what you're doing has merit.
Yes.
Yeah.
Exactly.
So I think probably it's time to wrap up and let people get on with their Saturdays. Alex, does anybody have any other questions that haven't been answered yet? No hands up. Nothing in the chat. Okay. So this recording, you're gonna get an email from me either later today or sometime tomorrow, depending on how quickly the download of the video goes. It'll have this in it for the replay, and it'll have that PDF that I shared with you. Of course, if you have any questions, anything else pops up, you can reach out. And we told you what we think, which is the more thorough and accurate your diagnosis, the absolute better. Please don't watch and wait unless you're really, there's just as Alex said, we hear from people who have gone the standard care route and are now struggling. So certainly our experience is not the experience of every cancer patient. I want you to know that we know that. And our job is really to be help you to have the most thorough and accurate treatment plan you possibly can. Make sure you're not wasting time on the wrong treatments, and just be able to get back to the fullest, healthiest you. So that's what we're here for. If we can help you with anything, do let us know.
Yeah.
Is there anything else? Yeah, go ahead, please.
I just want to say thank you, Michelle, for doing an amazing presentation here, and
Yes.
for all your work here. I have to give Michelle 100% credit for everything here, and of course for answering my questions that I didn't answer appropriately. Thank you very much for that.
Oh, you're welcome, Alex. Happy to do it. And obviously you folks can pick up what Alex is putting down. He knows a lot and when I say he's up at 3 reading cancer journals happily, I'm not joking.
She's not.
No, so really, if you ever have any questions, or you try the PubMed thing and you're not sure what the hell does this even mean, just know that we are here as a resource for you.
Yes.
That is the whole purpose of our existence. So
You can contact us at any time with any of your questions.
Well, I won't answer at 3 in the morning, but Alex literally may.
I might.
Yeah. Okay. It's been a pleasure to speak to each of you, and nice to see you, Mike. Thanks for joining in with us. And if you have any questions, let us know. And thank you for being here.
Thank you.
Appreciate it. Take care.